brain, it leads to stroke. If it happens in the leg arteries, it leads to peripheral vascular disease. So and then in the setting of a heart attack, and if you see my the slide on the far right hand side of my screen, when it ruptures, it's filled with a blood clot, and when the artery is fully blocked with a blood clot and totally blocks off the artery, that's when one experiences a full-blown heart attack or a full-blown stroke, for example. So this is a major problem, and we've been working on it for a very long time. You can see this is a statistics that comes from the British Heart Foundation. The age standardized mortality rate, the death rates, and the statistics essentially began in 1960, in the 60s. You can see that there has been a decline in the overall death rates with all the progress that we have done with the medications and the treatment of heart disease with procedures like angioplasty procedures or stent procedures. And yet, if we look at this, is the latest statistics again from the BHF, and I've included the most recent from 2020, diseases of the heart and the circulatory system is still taking a lot of lives. Most of them preventable. You will find through the course of my presentation that heart disease is preventable, unlike some of the cancers, for example, that we haven't really found the treatment for it. Most of heart disease is really preventable through lifestyle measures or through the treatments that we have available. Some statistics from the MINAP data, which is the Myocardial Infarction National Audit Project, around in a year, this is England and Wales only, Scotland and Ireland don't contribute to this data. We get around over 90, close to 90,000 heart attack admissions to our hospitals. And if you see the ST elevation myocardial infarction is heart attack, is the full-blown heart attack. So there's around 33,000, 34,000 full-blown heart attacks happening yearly in England and Wales. And then over 50,000 is relating to the minor heart attacks. And I've just I won't go into the details of the treatments in the slide. You can see it there. This is what bothers me. Again, this data is slightly older, 2014, 2016. I think if you still look at it, it might still be the same. So when you look at places like London, it's the darker the color is the higher death rate directly contributed to cardiovascular disease. And the one on the left is for all patients, one in the middle, I think it is for men, and the one on the far right is for women. So you can see north, as you come to the north of England, Wales, for example, in the Midlands, and more importantly, Scotland, you have a lot of darker colors, meaning there's more people in these areas, even to this day, are dying of heart disease when compared to, for example, the pinker areas in and around London, for example. So there is a disparity in the way, in the death rates due to cardiovascular disease across the nations. So the focus of my presentation is dealing with people that have not been treated well. I would use that terminology, or underserved so far. And who are these people? So I've been in Newcastle, trained as a trainee since medical schools for nearly 25 years. So when I was training, I did not see someone aged 80 or 90 in a cardiology ward, for example, or coming to us for procedures, because these people will be handled by geriatricians, and they probably would have been told, you know, you're too old to have any of these procedures. But today, this is pretty much the norm. More than 50% of our population that we deal with are aged more than 70 years of age. And why is that? Because our population is aging. And why, you might ask, Vijay, why is the population aging and why are we seeing that? It's because the progress in medicine is not only being seen in cardiovascular. A lot of people now survive cancer. A lot of people survive stroke. A lot of people survive other conditions. And therefore, as they grow older in their 70s and 80s, the heart disease catches up with them, and they present to us with heart attacks. So that is a growing challenge. but we don't have very much evidence in the best care of our older population with heart disease. So this is in the early 2014. So here, the older people, the lower end, I mean, I do apologize if these slides are too scientific, but essentially what these show is that the minor heart attacks happens more often in older people. And older people are likely to receive less medications in terms of even the basic aspirin, statins, and more importantly, the heart procedures that we do in a hospital. So you can see a number of headlines happening that were published around that time. So as I mentioned, more than 70 years of age represent around half of all heart attack patients that we treat. The first average age of first minor heart attack is about 70 years of age, and yet fewer people receive the contemporary guideline recommended care that we have. So only about 14% of people present to us, the people like myself who do the angiography procedure and stent procedures, among those aged 85 years of age and over. And this is sort of, what is the British Heart Foundation doing to address these disparities, as well as addressing the underserved population? This is kind of the funding the BHF is investing. They do spend a lot of funds as well as research project in order to improve the care of our patients with cardiovascular disease. So their main area of funding is stroke, followed by heart attack, and you can see the rest of the list. And the funding, where does the majority of the funding goes to? The larger the circle, the larger in terms of millions that gets distributed. So you can see London gets the most of the funding. That dot there up at the top in the northeast is Newcastle. That's the funding that we receive in the northeast of England. So in order to address the problem of how do we best manage the older patients with heart attacks, BHF recognized this, and that's the interest that I developed. So as I mentioned, when I was a research fellow, I did not, or a trainee, I did not see so many older people. But as I became a consultant some 12 years ago, pretty much all the patients that I was dealing with were older than 70 years of age, or mean age of 85 years of age. So, and I felt a strong desire. We don't really have much evidence in the management of these older patients. As you can see, in 2012, there was hardly any studies. This was the only study with a sample size of 313 patients. And when Newcastle University asked me, Vijay, what is it that you want to research on? And I said, we're now dealing with so many older people coming in with heart attacks, but we don't have any evidence. And subsequent, there were smaller studies. You can see a few studies that I have highlighted. So in the management of minor heart attacks in older people, the study evidence is in the range of just around 1,300. Most of the studies that we use to change guidelines and impact daily practice, the number of patients participated in the clinical trials will be in the range of 15 to 20,000. Not just one study, multiple studies, but the evidence to manage this commonly occurring heart disease in older patients is around 1,300. So there's certainly plenty of work to do. Therefore, the British Heart Foundation identified this as an important area to investigate, and they awarded us, myself as the UK Chief Investigator, $2 million grant award to study these older individuals that are presenting with heart attacks. So we have to date recruited 1,501 patients aged 75 years of age and over presenting with minor heart attack, and we allocated them to optimal medical therapy with medications only versus taking them to undertake invasive procedures, including heart artery test and stenting or surgical procedures. So this is the world's largest trial that we have to date, and we're delighted to be able to address this unmet need in our older populations. So this study, we hope to report next year, all being well, will certainly impact practice, change guidelines, and provide guidance on the better care for older patients, not only in the UK, but worldwide. So this is the recruitment graph. And of course, there's so many challenges to doing research studies. And of course, for the past 3 years, we've had the pandemic and we had to put the study on hold and restart. But we are delighted that despite all of the challenge that we have been able to deliver this important clinical study that will really transform the care of older adults with heart disease moving forward. So moving on from older adults, now the other underserved population are women with heart disease. And that being a woman, that really, really bothers me. And I want to give you a few examples to show you the challenge we have in terms of addressing this problem of cardiovascular disease in female patients. So this is one of my patients that I treated. These are moving a little faster, that just due to the AVI files rather than the actual patient's heart rate as such. One of my patients, 35 years of age, she presented 6 days later after experiencing the initial symptom of heart attack. So due to incorrect treatment, initially she went to the GP and she was told that she had indigestion and she was given indigestion tablets. The pain continued on, chest pain, back pain, not feeling well, generally unwell. Then she went again and the GP had to listen to her chest, and then she was given antibiotics thinking she had chest infection. And on the 4th or the 5th day, she wasn't looking very well. So the sister of the patient said, "You're not well, I'm going to call an ambulance." So as soon as the ambulance arrived, she had an ECG, and the ECG showed that she was having a full-blown heart attack. So I was on call at the hospital on that day, and this is the angiogram. So the heart arteries are like tubes that carry blood. So you can see, I don't know if you can see my the arrow that I'm pointing out. You can see when the artery is nice and open, it fills nicely with the dye that we inject. But here there is an absence of a blood. This artery right there is blocked completely with the blood clot. So she was very lucky. We went ahead and opened the artery, and you can see the artery is now fully opened up, and we put one long stent into her artery. So here the problem is she's young and she has been misdiagnosed. Even to this very day, people think that women cannot be having a heart attack. It's all man's disease. And that's something that we're trying to create awareness both among patients as well as among clinicians, because coronary artery disease is the leading cause of death in women in the UK and worldwide. And thankfully, my patient, she survived. She was very lucky that she survived this major heart attack, and she continues to do well. And she was able to go back to her family, her 3 kids. And on the same few months later, I see this sort of patients all the time. There's another one of my patients, 46-year-old. Again, she's very happy for me to share her history. Had bad chest pain around Christmas. But she didn't want to bother anyone, and she put her family first. And this is another story that I constantly hear from female patients. They are caring for everybody else, and they forget caring about themselves. So she put on with that pain, and thankfully, again, she survived, because a lot of people that experience heart attacks don't make it to hospital. 7 months later, in July, she was having ongoing pain that she managed to go and get some help in a district hospital where they did an MRI scan and found that something wasn't quite right, and she came. And then when she came, and I happened to be on call, and she had, we did the angiogram, and then it showed a blocked artery right there. So again, female patients themselves also don't think that they can be, and they put their family first instead of themselves and seeking help in a timely manner. Again, thankfully, this patient also, we managed to open up her artery, and I saw her in the clinic more recently, and she continues to do well. So some statistics on women and heart disease. Heart disease, again, I keep emphasizing this again and again because I really want not to terrify people, because as I said, heart disease is a preventable condition, and we want people to be aware of that and seek help in a timely manner. So 35% of all deaths worldwide is caused by heart disease, cardiovascular disease, not breast cancer, not cervical cancer, but coronary artery disease. So in 2019, again, 275 million women were diagnosed with cardiovascular disease. 8.9 million died due to cardiovascular disease. So if we think about the number of cases that could have been prevented and the reasons behind it, it just causes concern for us as clinicians looking after these patients. So far, women with cardiovascular disease have been understudied in research studies, under-recognized. I already gave you a couple of examples. Underdiagnosed, again, I gave you a couple of diagnoses. Undertreated and underrepresented in clinical trials. So again, for women, cardiovascular disease is the lead cause of mortality. So there has been a decline in the cardiovascular mortality in women, but in some country, you can see in the United States, Canada, also in the UK with the dotted blue line, there is an increase in cardiovascular mortality among women. So that, again, as researchers, does concern and ask us questions. What can we do? What can we do to change that? So awareness of heart disease is the leading cause of mortality among women has declined. So a lot of women think it's cancer that is the most thing, that disease that affects them. But in fact, as I mentioned, it's the heart cardiovascular condition. And again, just to also highlight that the Burchard Foundation also launched a major campaign called Bias and Biology to address the disparity in the care that women with cardiovascular disease have. I mentioned to you underrepresented in cardiovascular clinical trials. Women, this number 39%. So if you say there are 100 people recruited into a clinical trial, 75 would be men. That's my 39% from this study is slightly on the higher side. 25 would be women. So or even less, 25 or less. When there is high proportion of men and low proportion of women, how can we extrapolate the same findings in men to women? And I will give you some more reasons as to why we need to differentiate sometimes in how we manage the cardiovascular disease in the different sexes. So this again shows that there is an increase in heart attack statistics studies coming from Europe as well as from the United States, particularly in young women. So again, coming back to some of the studies showing women are less likely to receive guideline recommended care. What are these guideline recommended treatments? That's aspirin, cholesterol lowering drugs, beta blockers, angiography, and procedures like stent procedures and bypass procedures. And that is being shown both in the United States on the left-hand panel, and then in the UK from the MINAP database from England and Wales on the right-hand side. So you might say, so what, Vijay, if women are getting less guideline recommended care? And I looked into it in great detail, as well as some of our colleagues, other researchers in the UK. So as a result of women not receiving the guideline recommended care, they are experiencing, these are the curves. So you can see the survival curves. So women are on the bottom below the men, meaning they survive less when compared to men. So that's something for us to think about. Why are we not providing guideline recommended to care? And that actually is directly leading to poor survival in women when compared to men. I looked, because I'm an interventional cardiologist, I do the angiography and stent procedures. I looked at our database consisting of these stent angioplasty database, and that showed exactly the same. You can see this is the death rate. Women on the top line and have a higher death rate when compared to men, even after we do the angioplasty procedures. And some of the other findings, again, some of the studies that I have participated in as a researcher, women tend to bleed a lot. I mean, of course, there is the monthly menstrual bleeding, but after we give them any treatment for the management of the cardiovascular disease, or cerebrovascular disease, even stroke, for example, they tend to bleed more when compared to men, for example. And of course, many of you have joined in. You may or may not be aware that the primary risk factors for the development of cardiovascular disease is smoking. I mentioned this already, high cholesterol, diabetes, high blood pressure, or if you have a family history of heart disease. And these are what we call as the traditional risk factors. But women, when compared to men, have some additional risk factors for development of heart disease down the line, which are the pregnancy disorders. So if a woman, for example, experience preeclampsia, eclampsia, or high blood pressure during pregnancy, gestational diabetes, for example. So this is only the woman could be in her late 20s or 30s. So during pregnancy, she experiences all of these conditions. And then, of course, the baby is born, everything settles down, all attention goes to the family and baby. And most of the time, nothing has been done to address these pregnancy-related problems that women experience. Now we're having a lot of studies that are coming that women that experience these conditions during pregnancy have twice as much higher risk of developing cardiovascular disease, including heart attacks, for example. So that's something that we're trying to really address, that working together with the gynecology and obstetrics colleagues to make sure that these women are monitored or even provided with appropriate therapy in order to reduce the future risk of cardiovascular disease. And the other thing, everybody will experience that as we grow older, menopause. So for women, of course, the estrogen has got a lot of protective effect on the inner lining of the blood vessel that protects the arteries from developing this lipid, the cholesterol buildup in the wall. So as menopause happens, the estrogen level goes right down. And that's when, again, women tend to experience a lot of cardiovascular problems, including heart attack. And there are ways to address that, addressing blood pressure, addressing diabetes. And that's something perhaps has been ignored, and that's something through the various work that I'm doing, we're trying our very best to address, and also other conditions, polycystic ovarian conditions, etc., etc. So, and the pandemic, again, I live in the north of England, and some of the statistics that came through over the pandemic really opened my eyes. So particularly, I mean, this is a map from the government. The darker the color is the most deprived. So if you live in a most deprived area of the Great Britain, despite the National Health Service that we have, when compared to other countries where people have to pay for their health services, particularly for women, if they live in the most deprived areas, experience higher mortality or death when compared to men, for example. And again, this is something that I was very bothered with. So some of my former fellows put this together and really confirmed that. And again, coming back to the same thinking, why is low socioeconomic status attributing to more deaths or more heart attacks? And that's down to the same phenomena. There is excessive risk factors, smoking, alcohol consumption, unhealthy diet, etc. So with all of these in mind, again, with the even before the pandemic, the Lancet, which is a major medical journal, commissioned this particular commission called the Lancet Commission on Cardiovascular Disease in Women to reduce the global burden by 2030. So we looked at a number of aspects of a women's cardiovascular health so we can bring down that, the curve, or equalize with men or bring it down by 2030. 2030 I think, is very optimistic and ambitious, but we're doing our very best. And I'm very delighted to be the UK commissioner on this commission together with 17 others from the 5 continents of the world. So one other thing, women also, I mean, I mentioned to you, it's the blocked artery that causes a problem. And again, over the last 3 years, I have been, with all my research, become more conscious that women have unobstructed arteries and yet have higher problem, so subsequent heart attacks and reduced poor quality of life. And as a result of that, together with a lot of the European colleagues, I put together this consensus document on the non-obstructive coronary arteries, and it really raised the awareness of this condition worldwide, encouraging patients to seek help, as well as the researchers to do more research on women with non-obstructed coronary arteries, and yet they come to visit us with symptoms and further problems. This again is a recent study. Again, it's quite busy, but I just want you to focus on the curves. So especially the curve on the top right-hand side, where the bottom line is for women and the top dotted line is for men. This is following, I looked at around 13,000 patients that we dealt with in the north of England. And again, it confirms that when women come in with a blocked artery in the context of a heart attack, have reduced survival when compared to men. And that again is really a cause concern. And we're doing a lot of work in order to see what are the challenges there and how can we cause shifts in the curve and improve the outcomes for our female patients. And given half of the world population is female, and we really can't have these underrepresentation and particularly unnecessary loss of lives. And we've written a number of papers. This is a publication by one of my former fellows, published in the Heart BMJ. You're all very welcome to read it. But again, emphasizing the importance of doing more research studies in order to improve the health and well-being of our female patients with cardiovascular disease. So again, it's the same thing. It's ischemic heart disease. There are a number of risk scores that we use in the best care of female patients, but then you can see on the right-hand side all the studies that has been done with thousands and thousands of patients, and yet the representation of women is around 30%. And we want to understand, particularly given women have much different risk factors, as I mentioned, more gynecological or obstetric related risk factors that directly contribute to the development of cardiovascular disease in the future. So there is need for more studies, and we can't do studies. I'm a researcher and I'm a doctor looking after patients. I can't do studies without funding. And again, through our Lancet Commission, I've just come back from New York, where we discussed our Lancet Commission in great detail, raising awareness, and particularly among funders, so they will invest more funds in order to do more research studies, so we can find the best treatments for our female patients. So again, a lot of these has been covered in the media as well, in particular following the publication of our Lancet Commission. I think these are from the Daily Mail. Women suffering because of heart care gender gap. Women still suffering needlessly due to heart care health gap. So, and women are more likely to be misdiagnosed for heart disease and heart attacks than when compared to men. I already gave you the examples. So I hope I have been able to give you some glimpse into some of the disparities, health disparities that we have, particularly in relation to cardiovascular disease. And I'm particularly determined to address these, and I can't do it alone. And for the Seniorita trial, we have 52 other NHS trusts across the UK and our colleagues that are supporting us with that. And we need to come together with the involvement of public and other colleagues who are interested in improving this or seeing a change in these disparities. So I thank you very much for your attention, and I will hopefully we can open it up for discussion or any questions that you have.
Brilliant. Thank you so much, Vijay, for such an interesting talk. I'm sure I speak for a number of the attendees when I say that you certainly opened my eyes to the disparities in cardiovascular care and how it's been managed. I'll start off with one question that was submitted in advance of this webinar. That question is, I would be interested to know if the experts have statistics regarding ethnicity and how this is linked to perception of pain tolerance for BAME people.
Yeah, thank you, Anna. That really is such an important question. So we are indeed, and again, the COVID really opened up our eyes to see. You can see I am if you call I don't like the terminology. I'm Asian ethnicity, and also to see the our patients that are from the Black and other ethnic minority groups experiencing a higher level of infections and death just because of their ethnicity. And in relation to pain perception, that's so important and particularly relates to women. So men, when they have a heart attack, they would experience it like a tight band across the chest. And they are more likely to, ring an ambulance, or their wives are likely to ring their ambulance, children, whoever is there. But for women, I will start with women and then I will go into the ethnicity. Women, majority of the time, like the two examples that I gave you, the examples that I gave you were Caucasian. But despite that, women, up to 80% of them do experience when they have a heart attack as a tight band across the chest or chest tightness. But women tend to have a lot of other features. They might generally feel unwell, nausea, sleeplessness, breathlessness. So there's a lot of other characteristics that are associated with. So if you have nausea, just like my patient, they will think it's actually indigestion or something. And so there are some studies showing that. So because I've just given you the statistics, that I don't really want to scare people, but what I'm trying to do is to make sure that we get help. Could this be my heart? There's no harm. There's no harm in ringing 111 or your GP. This has not gone away and I'm not feeling right. And I've got a family history of heart disease. I have diabetes. I'm just giving you some examples. Could this be my heart? There is absolutely no harm in doing that, because when you come to us sooner, there is more thing that we can do in order to help. But your question on ethnicity, to my knowledge, because of the representation of ethnic minority population in clinical research is so low, we're not able to, and that's something we're again very conscious that we need to not only make sure that there is increase in sex representation in clinical studies, but also we want to make sure there's more representation of ethnic minority patients in our studies, so we can understand all of these questions that we have.
Really interesting. The second question is actually from me. As you very clearly explained within your talk, more awareness needs to be raised amongst women that they can suffer heart attacks. But from one of the examples you gave, it appears that there may also be issues with awareness in primary care. I'm thinking specifically about the example you gave with the 35-year-old who presented with the GP and was told it was indigestion. How do you think awareness is best addressed amongst medical professionals?
Yeah, exactly. So, and again, this is something when someone is having a full-blown heart attack, going to the GP or visiting the general practice is not the right thing to do. In the whole of the UK, I don't want to go into the challenges that we're facing at the moment. Hopefully, it will be resolved and we can go back into the way of caring for our patients and delivering care as best as we possibly can. But when they're supposed to ring 999 and they are really supposed to come to the hospital, and they will take them to the place where the heart attack treatments are provided. So thereby avoiding any kind of intermediary. So there are so many studies. If people go to another hospital without a heart attack or angioplasty procedure facilities, then that leads to poor outcomes in patients. So I think for heart attack, it's in the care of our public. Number one, because they are the ones that are experiencing the problem. So instead of calling anyone else, we'd rather they call 991. And with regards to other colleagues, including general practice or other acute medicine, being aware of, is this heart or the misdiagnosis? Again, we're doing a lot of work because every specialist is extremely busy with what they're doing. So a general GP might see so many patients with different varieties of conditions. So And you can see it could easily be missed. And again, this is something that, again, we're working with our primary care and all. It's one person can't do it. It's a collaborative effort. So doing things like this, or going on to public health campaigns, in which we have done through the British Heart Foundation, all of these helps raise awareness, so we're not missing these important diagnoses for our patients. And as I said, it's a treatable condition. Very, very rarely we say there's not a lot we can do about your heart. So these are preventable aspects of cardiovascular care, and if people come to us in a timely manner, then we can certainly help them.
I have one more question in the chat at the moment. This comment: thank you for such an illuminating talk. Can you please elaborate on the extent to which age plays a part in misdiagnosis, and is there a trend towards younger people suffering more frequently with cardiovascular disease?
Yeah, again, that is thank you so much for your kind words. And also for this very important question. Similarly, same. You can tell why I got interested in the older people and women. Similar kind of pattern. So I showed you in the national statistics that 50% of heart attacks, at least the minor heart attacks that we see every day, happens in people that are aged 70 and over. And again, as people get older, they present with a diverse symptoms, not the classical. They might just generally feel unwell, or it might just be general breathlessness. And again, in the UK, as you would know, dementia, cognitive impairment is another major health problem. So a lot of our patients that we see, they might have some element, in the older population, will have some element of cognitive impairment, for example. In one of the studies that I did in Newcastle, consisting of 300 patients, 75 years of age and over, we found that up to 48% of patients that we actually see presenting with a minor heart attack indeed have cognitive impairment that has not yet been diagnosed. So that's a whole new element. So when somebody has a cognitive impairment and experience a heart attack, their presentation simply might just be delirium or confusion, for example. And when somebody is presenting with confusion or delirium, heart attack is not the first thing that's going through their mind. And of course, they might get treated for urinary tract infection or chest infection again. So it's a similar pattern with women also. And again, through the number of studies that we're doing, we're again raising awareness, both through the papers, research papers that we publish, as well as going through the media to raise the awareness that indeed for older adults, heart disease, is the lead cause of mortality. And if you actually bring them, and of course, if they're in the hospital, inevitably they'll have their bloods tested, and the blood will show if there's a raise in the blood, the heart enzyme or heart biomarker rise. And then once again, if there is a rise, then they will get the help of the cardiologist and will look at the ECGs and make a diagnosis whether the patient has had a heart attack or not. So yes, indeed, the answer to the first question is very easily older adults can get misdiagnosed and treated for other things than heart disease in itself. And one thing that I wanted to, and one of my patients who was 93 years of age, she got admitted exactly with the same symptoms. She became confused and delirious. And thankfully, when she got admitted into hospital, they did the ECG, which clearly showed that she's actually had a heart attack. And then her blood markers were raised, which is consistent with a heart attack. And then she got transferred to my hospital, and I was on call that day, and we did the procedure, and she clearly had a couple of blocked arteries. And on the day, we decided to open up the artery. And as we were opening up the artery, she became very alert and she started talking, and it's incredible how there is a heart, we're doing a lot of research on heart brain connection. So when the heart function reduces as a result of maybe reduced blood supply, and that leading to impaired heart pump function, it affects older individuals much quicker than younger individuals, for example. And then I have seen, again, treating the heart helps improve the cognitive function of older people. And we've published a number of papers with regards to that. And then in particular relation to the question on a trend towards younger people suffering more frequently with cardiovascular disease, again, during my presentation, I showed that worryingly, heart disease, particularly heart attack, is increasing. There was a downward trend if you look at the global statistics of reducing death rate, but in the last decade, there is an increase in the heart attack presentations among younger women. Younger women, that's a fantastic question. Thank you so much for asking. And that is mainly could be that maybe women in the past used to have the heart attack and didn't get help, but now we have more powerful blood tests that can detect heart attacks. So it could be that we're picking up more heart attacks in young women when compared to previously. That could be the reason. And one thing I did not cover in my presentation is women, although they have different risk factors, they could also have other conditions like coronary artery spasm, for example. I know of several patients who struggle a lot with it. So at the beginning of my presentation, I showed that the artery can be blocked as a result of the cholesterol being deposited. But the artery can also be blocked when the artery in itself goes into a bit of a spasm, when there is constriction. The walls are perfectly fine, but it goes into constriction. And I have seen patients presenting with heart attacks as well as cardiac arrest as a result of that. And sometimes when we do the angiogram and find arteries are completely fine at the time, spasm come and go. So when it comes is when the person feels the pain or ECG changes. Then when the spasm is relieved and the artery is fully open, they're fine. And they've been told nothing wrong with you, go away. But we can give medications to prevent the spasm from happening again. So that's one of the conditions that happens more often in women. And the other condition, particularly among pregnant women, and again, young women, is what we call as a spontaneous coronary artery dissection. So the artery wall will be perfectly clean, but there is a tear on the inner lining of the vessel, meaning once the tear is happening and there is a gap in the wall, and then the blood fills it. And because the blood fills it and the wall gets thickened, and the lumen can be reduced. And we see that more among women in the pregnancy age group women. And again, that has been misdiagnosed for a long time, but we now have a number of studies and what can be done. At least once the patient knows that she's got that particular condition, then she can get help faster next time than if she's been told nothing wrong with you. And there are other conditions that I really want to emphasize here is that women's heart is more sensitive to stress. All of us, again, this is not to panic anyone, but it's more of raising awareness that when you're stressed, what happens? There's excess adrenaline. So the adrenaline directly affects the heart. And we see what is called as a broken heart syndrome. So the heart literally balloons out. It's called as Takotsubo cardiomyopathy, or ballooning. And so the answer to that is don't be stressed, but it's easier said than done, I suppose. But I guess when we raise the awareness, and we again see that more often in women, again, we didn't know much about it in the past, but we are now beginning to learn a lot more about it as a result of investment in research and female patients willing to participate in studies. So we can't simply tell the researchers, you're not enrolling enough patients, but it's also in the hands of female patients. Actually, yes, I do want to participate in studies so you can gather the data and the doctors and the researchers can find the best treatment. So we don't want to see these under treatment in the next decade, for example, all of these undertreated, I really would like to see all of these undertreated and underdiagnosed conditions in the next decade being treated.
Brilliant. Thank you, Vijay, for answering our questions so comprehensively. I echo the comments of those in the chat that it has really been a fascinating and illuminating talk. I think unless anybody puts their hand up, those are the questions we have today. Okay, yeah. So I think all that remains for me to say is thank you so much to everyone for attending today's talk. And please look out for further invites to Urban Mitchell's upcoming Health Inequalities webinars. Thank you very much, everybody.
Thank you very much for having me.
Thank you.